Hello everyone and welcome to the Health GoLIVE webinar series. Today's episode is brought to you by our friends at CareCentrics. Just a few housekeeping items to go over. We would like to remind everyone that the Q&A feature will be available, so feel free to send in those questions for the panelists throughout the discussion. Please join us after the webinar for a guided meditation with Daniel from Mindful. And with that, I'll throw it over to our moderator who joins us from CareCentrics, John Driscoll.
Welcome everybody. We are absolutely thrilled to curate and lead what's going to be a great discussion about bringing healthcare home. I mean, certainly it's time. We've got a bunch of great CEOs and CMOs and entrepreneurs who I'm an admirer of, who are helping make that promise of care to the home a reality. We're going to talk through some of the challenges of thriving and surviving in a COVID environment, a little bit about some of the new avenues to innovation around care to the home that have been opened up, and as well as some of the challenges of sort of the traditional medical industrial establishment. But before we get into that, maybe I'll just ask each of my panelists to introduce themselves, maybe starting with you, Robin, if you could describe a little bit about who you are and what you do and what your organization's aimed at.
Sure. So, well, thanks for having us. Thanks for asking us to be here. It's an exciting time in healthcare and looking forward to the conversation. So my name is Robin McIntosh. I'm the co-founder, co-CEO of Work at Health. And Work at Health is an addiction technology company. We offer a range of telehealth recovery programs for people seeking clinical help for opioid use disorder, alcohol use disorder, and other process addictions like eating disorders, gambling, etc. My background specifically is a blend of design, development, marketing, and business. So that's the perspective I can bring to bear on the conversation. And yeah, I'm excited to be here and looking forward to the questions, John.
Awesome. Dr. Daniel, can you introduce yourself and a little bit about kind of what Best Buy is up to?
Absolutely. I'm Daniel Grossman. I'm the Chief Medical Officer of Best Buy. I'm an emergency physician part-time, and at Best Buy, I lead our strategy and partnerships team for Best Buy Health. Best Buy Health came about over the last couple of years through a series of acquisitions, really thinking about how do we enrich lives through technology. And if we're going to enrich lives through technology as Best Buy, one of the ways in which we need to do that is to help healthcare come to life for people. Health is a huge need, and that's where Best Buy is focused.
And Toby, could you describe a little bit about not just who you are and what you're up to at the Cleveland Clinic, but a little bit about kind of some of the more entrepreneurial things you've gotten engaged with that are very much part of kind of care to the home.
Well, thanks very much, John. I'm delighted to be here. First of all, I'm a recovering heart surgeon and previously stepped down about 2 years ago as CEO of the Cleveland Clinic. Since that time, I've had the opportunity to work with Google as a consultant, and I'm also on the board of American Well and companies that are increasingly attempting to democratize healthcare delivery.
Speaking of democratizing healthcare delivery, I can't think of a harder category than behavioral health and addiction, Robin. Can you talk a little bit about, I think it's remarkable that we're turning something that there's real issues of access in the physical world into the digital, particularly at a time when there's so much unmet need. Maybe you could talk a little bit about how you got to this particular business and how the value prop is working itself out in a time when there's a lot of unmet need based on the social statistics we're seeing during this time of kind of COVID trauma.
Sure. Some big questions in there, but yeah, of course. So with Work at Health, I think we're in a unique position in the industry, at least in the addiction industry, in that we were mobile from the beginning. So mobile first from the beginning. And I think that's due to kind of a specific complexion of our team. So my co-founder comes from a clinical background, but also a product background. I come from marketing and digital design, so we always had kind of the thought of going mobile first. But for us, it kind of, the final result of choosing to do this and be a telemedicine provider of addiction services is really stemming from the problem in our specific vertical, which I think really does relate to chronic conditions, widespread chronic conditions. So for us, in addiction treatment, there's kind of a dilemma in this country and everywhere in that we know it works and we know that addiction treatment works, but nobody gets to it, right? Like, so 9 out of 10 people that are diagnosed with substance use disorders don't get the addiction help they need. And if they do get that help, if they're one of the lucky ones, they most likely will relapse within the first year. So that's where we started at Work and Health. We said, okay, there's this huge problem. I'm in recovery myself for 15 years from drug addiction and alcoholism, as is my co-founder. So it was before the opioid epidemic sort of, blitz the headlines, et cetera. And we just said, why are all our friends dying? Like, what is happening here? So it really boiled down to for us to 2 things. So 1, cost, and 2, accessibility. It's very expensive to get addiction treatment. Oftentimes, you have to go away. So it's inaccessible in that way. You have to go away, or if it's an intensive outpatient program that could be Monday through Friday, 9 to 6 p.m., you'd have to take leave of your job and your family, et cetera. So in UX, user experience land, you have an acquisition issue and you have a retention issue. So of course, this naturally led us to wanting to push a digital first solution. So 1, it helps with cost. It cut out a lot of the overhead expenses that we were seeing in rehab centers, et cetera. And 2, there's nothing more accessible than the internet and your smartphone. We thought it was atrocious that it was harder to look for an AA meeting than it was to order a pizza, and we mentioned that quite a bit because our whole goal was to make it easier. So you have us doing that in 2015 and a lot of other companies doing that. And then when COVID hit, it just accelerated, I think, from a healthcare standpoint, but really consumer adoption standpoint, telemedicine trends. So people, because they didn't have the option to go, and my other panelists can talk about what they're seeing as well, but because people didn't have the option to go in person, they were kind of forced to do telemedicine. And that's kind of, we've seen people adopt it, move from kind of the early adopter stage of telemedicine rapidly to kind of a widespread stage. So we're excited about that.
And are folks, when you think about that, are the natural tendency would be say, how much can you really accomplish via digital versus in person? I mean, what have your results been?
Yeah, so we have had to do this quite a bit, right? Like, we've had to defend telemedicine for a lot longer than COVID. And luckily we're not alone in the space, and that telemedicine is more and more studied, and there have been more and more trials on it. But for us, we see incredible results when it comes to retention and adherence. So retention, it's kind of, you don't really need like extensive trials to really understand this point of view, right? Like, of course, it's going to be easier to do asynchronous texting with your counselor than it is to go in person and meet with someone face to face, right? It's always going to be easier to drop into convenient drug testing hours than it is to line up at the methadone clinic across town at 6 a.m. every single morning. So there are all these ways that clinically, but also from a product perspective, we're able to kind of fit to the needs of the individual patients and fit to their life circumstances through telemedicine better than an in-person brick and mortar across town. So
that dramatically democratizes access. I don't know, Toby, would you have anything to add based on either the clinic's involvement with telemedicine or your involvement at Amwell? Certainly, I think probably Daniel and I both have been part of conversations where people were just super skeptical of digital first solutions or telemedicine as anything other than kind of solving for sort of the old urgent center problem of needing to talk to someone about a kid with a fever of 101. Like, what do you think about the effectiveness of telemedicine broadly cast and digital, and what's been your experience?
The experience has been, it's been very difficult for 2 reasons to get it up and off the ground. The first is reluctance by the physicians, and the second is lack of exposure by patients. Interestingly, once the patients have tried it, their satisfaction is greater than it was to going to go and see a physician at the hospital with all that involved in our office and all that entailed. Now, I think the expansion of this is seen in the ability to do things like during COVID, 94% of the Cleveland Clinic's diabetic patients were managed by telemedicine. You can imagine the same thing being able to be applied to hypertension, for example, which is you're going to have closer control of both the blood sugars and blood pressure by doing frequent visits via telemedicine. Then run it out into home care where, and think about things like Alzheimer's disease. When you have to bring somebody with Alzheimer's disease to see a physician, a tremendous amount of effort and really not a lot of physical contact is required to do that. Neurologic diseases, same sort of thing. So I think the applications of it, you know, even beyond psychiatric problems and addiction problems are going to be enormous. And I think we're just tapping the surface of what this means. It's an awful lot of things can be done without having to physically touch a patient.
And how effective, I mean, everyone realizes that in this crisis, people were doing stuff at home, and we've been trying to sell more care at home, leveraging nurses and PAs and extending physician extenders, remote patient monitoring, care-centrics for a while, but there's been enormous reluctance because the assumption is if you had to do it digitally and remotely, that it would not be done as effectively. What was the experience with the diabetics? Because certainly that same kind of infrastructure and extension of care is something that we in Best Buy agree on, but there's been a fair amount of reluctance on the part of the docs in the hospitals. How effective was it? I mean, diabetes couldn't be more complicated.
Well, I think it's been terrific. And in fact, the reason it's been terrific is people just get more monitoring this way. I mean, why on earth do you need to go to see a physician to get your blood glucose checked or your blood pressure checked, or see the progress of your neurologic disease, or, you know, a whole raft of things that you're going to be able to do? I just think you're going to have better and better care on a longitudinal basis by reaching out to people. Not to mention less expensive.
And Daniel, if you think about, maybe you could describe a little bit about the web of services and investments Best Buy's made, because to some degree you're helping build out, you Best Buy Health, the infrastructure that could create more opportunities for companies like care-centrics or doctors that are doing innovative things to the clinic or work it kind of fit into a more holistic home-based solution.
I think what's happened is, of course, the world has converted, but it wasn't set up for success in that conversion. While the number of visits has grown exponentially and are now coming back down, and the care that people with chronic conditions or acute conditions, or you know, they're getting better care and they're getting their blood sugar checked more frequently. The technologies that actually round out that set of services weren't available in the home. They're not yet available in the home either. And they're not necessarily designed for someone to use them on their own, maybe without a physician or a medical assistant or a nurse helping. And so that sort of consumer centricity or patient centric technology design to have the right equipment in the home hasn't happened yet. And so that's why we'll see sort of a regression in telemedicine use until the home is actually appropriately outfitted for optimal care delivery in the home. That won't happen yet. And so Best Buy has through a series of acquisitions, and then also how do we leverage our existing technologies, our existing in-home services. You know, you trust us to come into your home and set up your home system, your home smart home or technology. Do you trust us to come into your home and also set up the equipment that's needed to deliver Cleveland Clinic's top-notch care, or Mayo Clinic's top-notch care, or the addiction services that Robin has to offer? And I think that's the next step, which is democratizing actually the technologies to make care delivery so successful.
Let me just add on to that just for a second, because I think he's absolutely right. I mean, you look at the technology now. You now can do an EKG with your cell phone. Now, on top of that, we're now seeing AI begin to be able to predict when someone's going to go into afibrillation in the next 6 months. We're now being able to, at home, use this technology to monitor people who are going to have cardiac rhythm problems secondary to chemotherapy. These are big opportunities that go forward. Once you have the technology, then you've got a whole bunch of things you can add on, including AI, which really makes it very exciting.
Yeah, I mean, just on that, Toby, do you want to double click on that? Because really, once you go digital, and then Robin, I'd love you to comment on it as well, you've actually got a much richer, assuming it's pervasive to Daniel's point and accurate, you've got a much richer and more real-time set of data to feed into not just algorithms, but doctors. And I just think that's, in some ways, it enriches the opportunity to personalize and target care. But can you speak to that? Because you're both on the Google side and Amwell and the clinic, you've got a bunch of toes in a bunch of ponds.
Well, the interesting part about it is collecting the data gets into a whole bunch of issues. The first issue is, I think clearly we've got to go from just storing data in individual data centers to use the cloud, simply because you can collect more data, you can have, it's more secure, you can get at it faster, and then you can begin to use the AI potential to understand that. So I think that's an enormous step. Now, the issue really is about privacy. And that is becoming an enormous issue, that people are worried about their healthcare data and privacy that is associated with it. And I think, frankly, the solution to this is, one, have a third party monitor the ability to keep the data private. And secondly, the data can be used for analysis with permission. And the ability to have major data sets gives you enormous opportunities to understand diseases, predict diseases, treat diseases in ways that we can only begin to imagine right now.
Robin, do you want to comment on that? Because I would imagine that digital first, again, gives you sort of an information advantage in being able to target personalized care.
Yeah, well, I mean, in our industry, we're working from like a crazy standard, right? Addiction has been a black box for so long. You basically close your eyes, sign over a check, and you go away to Arizona for 30 days. Like, I think that's what happened to me, and that's happened to a lot of people. So we're working from kind of a zero basis, and we're starting up from there. It's interesting to hear Toby. He's totally right about privacy and privacy concerns. On the flip side, we're finding that most of our patients are coming to us because of the privacy advantage of telemedicine, right? So with addiction specifically, it's a stigmatized issue, and people don't want people to know that they're getting help, and they don't want people to know that they're an alcoholic. It's hard to go to an AA meeting and expose yourself to maybe your mayor and your neighbor and your dentist or whoever you imagine to be there. So that's interesting. So it's kind of the fear of privacy on one side, but on the other side, it's this embracing of the privacy of telemedicine models. And then the home, and telemedicine in the home. I think interesting, Daniel, to your point, I was thinking about Best Buy over the weekend, and kind of, my sister is in town and she's an occupational therapist, and she outfits her patient, she's home health. So she outfits her patients. I was telling her about Best Buy and she got really excited because she outfits her patients to be these virtual care settings, so these hybrid settings. And one thing we were talking about, what we've seen as a result of COVID is something that comes from, actually it's kind of borrowed from the UX world, right? So in user experience, what you do is you look at a patient's journey and you say, where can this patient or user make investments, right? And so you pass the onus of some things onto the patient so that they psychologically make an investment, and then they have more buy-in in the care. So I think it's kind of like if I have Nest for my house, using Google as an example, I'll be more likely to tinker with the thermostat every day, right? Because I set it up, it's my smart home, et cetera. So I'm interested in kind of the user experience side of the house, where if you kind of induce patients to make these minor investments, can we increase retention, and can we increase adherence that way? A small example at work, something you traditionally would never see, right? But we've passed ordering drugs, so we drug test all of our patients. No surprise there, but we've passed ordering drug testing supplies and tracking shipments onto patients. And this is something physicians would never tell us to do, but we have a large UX team, and the UX team wanted to do this. And what we've seen is an uptick in adherence, especially to drug testing, because they have agency and autonomy over that process, right? It causes a psychological buy-in, so they feel they're more a part of that care and a part of those care settings. So I think there's a lot of unexploited, unexamined potential there too, John. Like when we talk about
Totally agree. I mean, one of the things we really focus on, as Toby knows at CareCentrics, is creating agency and empowerment through information connection, and really bringing back the patient and the family to own their care journey around their goals, because there's a unintentional infantilization in many cases of the medical industrial complex, which takes your illness already beats you up, and then the complexity of the system, which we try to solve for. But one of the things we've been shocked by is the power of personal engagement and coaching around individual goals. I mean, but I love, Daniel, your thoughts on this, you know, as a practitioner, as well as kind of how this fits into the vision of what you'd like to create, because certainly we just think there's a lot of more opportunities. And then maybe speak to, again, or build on Robin's point about user-centered design, because I do think Best Buy is also super consumer first.
Yeah, so I am passionate about human-centered design, user-centered design, user experience. Take your pick of, you know, the words you want to use. The traditional healthcare system doesn't think about each individual patient and the patient journey they're on. We can map a patient journey pretty well, but the inflection points that happen along the way, they're not necessarily considered when we offer someone a solution. And I would have, you know, one of my visions for Best Buy is that you can actually come in and say, I've just been diagnosed, to Toby's point, with Alzheimer's. And we have actually an entire suite of solutions. We're not there yet, but can we actually recognize all of the inflection points that are going to happen along that dementia arc, and actually come to your home and maybe use an occupational therapist to understand exactly what you need along the way. Smart lighting, so we know that someone who has Alzheimer's is going to wander, and make sure they don't fall. Bed alerts, so that their caregivers alerted when they've left the bed and if they haven't returned. I think there are all kinds of technologies. You know, I'm a patient myself. I had a spinal cord injury 3 years ago, and one of the first things I did is outfit my entire home with smart lighting and with Nests and with all of these things for voice activation, because the last thing I want to do is get back out of bed after I forgot to shut off a light. I have the privilege and the capability to do that. Many people don't. What then you want to think about is, for different subsets of folks with different resources, how can we design a solution for you that works, or for you that works based on what you need? That user centricity, patient centricity is something that a consumer electronics company or a retailer understands that a traditional medical system may not, and that we know is true.
I know it's true, but you've been on both sides of it. Why is that so true? Because honestly, it you know, a lot of what we focus is care traffic control and trying to rebuild the bridges across care transitions that are sort of predictably broken. Like, what is it about the healthcare system that keeps creating opportunities for entrepreneurs like you and me to fix?
Well, on one hand, I would argue that, like, a lot of people just bucket a patient in, right? Like, you're a patient with spinal cord injury. Yeah. The first thing I was told was, sign up for Medicaid. That's what people with spinal cord injuries do. Instead of saying, like, what is it that drives you? What is your home life like? What support system do you have? And then shaping something around that. The benefit of having customers who come back over and over again is that we can collect information on them. That sounds dangerous, but in reality, what it allows you to do is customize people's experiences. We know what you're going to buy during the holiday season before you know what you're going to buy, and we're going to help you buy it. You didn't know you needed an air fryer, but I bet a lot of you listening today bought an air fryer last holiday season. It was one of the big ticket items. We know that, we can plan for that, and we will help you get the right air fryer for you. Now, that just has to be applied to healthcare in a new way. And that's the user sort of consumer centricity or consumer obsessed focus that we have. And maybe I'll just give it one small example from a telemedicine standpoint. We were on a call with a health system, and they said, could you, Best Buy, please help our patients who are using telemedicine better navigate the waiting room so that our physicians are more efficient? That's a physician-centric or system-centric model. That has nothing to do with the patient experience. It just is making my physicians make more money. make the patients the center of everything, and you're going to transfer, you're going to reinvent how care is delivered, and that's what we need to get to.
Yeah, and I think you really touched on something. You know, we built a lot of our post-acute programs around the Eric Coleman model, which is around what are your goals, not what is the healthcare system's goals, and not looking at a patient as a transaction to be cleared, but or a procedure, but really looking at asking the question to be let in on what are you and your family's goals, because that's empowering. But it also, I think, can tune you towards what's going to motivate people to own their own healthcare. Same question for you, Toby. Have we captured everything about why the medical industrial complex gets it wrong? And you know, and please, you know, and I know that Daniel got a little air fryer sales work in there, and I'm sure you'll get a plug in for the Cleveland Clinic. But even with that, what about the rest of the healthcare system? What's it getting it wrong, and how could we fix it and create more of these alternatives that are more patient-centered?
Well, first of all, I'm really pleased that so many industries now, you know, be it the tech companies or the big retailers, are getting into healthcare, because I think it will make us and force providers of healthcare to think differently about what we do, and they're going to bring a great deal of value, and I'm delighted. Now, one of the problems I think with healthcare is doctors, and let's face it. We doctors were selected because we did really well in organic chemistry. And then we spent 4 years in medical school memorizing. And then we spent 3 to 6 years in residency when we did just what we were told. And so we were selected not to be creative. We were selected to not be original thinkers. We were selected not to be innovators or entrepreneurs. And we were trained that way. And that makes the process of innovation in healthcare a very long one. Going to 13 years from an established therapy or technique to standard of care. That's just too damn long. And, you know, we've got to think about people being more open-minded and more willing. And I think the fact that other industries have now recognized this as a huge economic opportunity and beginning to address it is going to be great for healthcare.
You know, Daniel, you were, when some of our earlier conversations or other conversations, you talked about the speed of learning and implementation. Maybe talk about the speed of innovation in retail versus healthcare, and don't depress us too much, but I still think it's a pretty powerful, you know, an analogy.
Yeah, I mean, I was new to retail, and I was blown away by how quickly we had to convert our business for COVID. And, you know, we had to shut our stores, and we were deemed an essential retailer in many places. And we weren't going to let people in the building. And that required us then to implement a curbside system. Now, to be fair, healthcare has had curbside flu shots, curbside COVID tests, you know, the curbside system's alive and well. We had a tent outside one of our hospitals for overflow, and that works. But to convert retail into a curbside model where you order, indicate that it's curbside, we tell you when your order is ready, you tell us when you're there, and someone brings it out and puts it in your trunk and walks away. That experience and designing that within a week is just something that I don't think traditional healthcare companies can do. There are a lot of rate limiters to that. And furthermore, there's a lot of infrastructure that is already in place that must be maintained and has to have revenue generated from it, as opposed to what are you going to convert your existent retail footprint to do differently. That speed of innovation was fascinating, and I might be getting a Toby eye roll here, but I was blown away by retail's ability, and multiple retailers did this, to just convert on a dime and to actually exceed what was happening before.
Whether you get the eye roll or not, Toby, I think we've talked about this in other conversations about how quickly in a combat environment, when you watch the military adapt like that to whether it's blood supply or surgical technique. Maybe speak to some of the innovations you saw as a combat physician and the speed that healthcare can actually adapt on the fly in real time when there's true pressure and you've got the domains freedom to actually change techniques, which happens in wartime.
Well, I think demand is really the amazing thing that happens, and what you can do when you have to is beyond anybody's belief. I mean, one of the things I learned in Vietnam is I ran a 100-bed hospital with 2 doctors, 13 nurses, and a score of corpsmen, and they did all kinds of things. And I think that we have limited the ability of our personnel to do lots and lots of things that they could do very successfully without having an MD or an RN after their name. So, this is the military at its very best, changing, moving people to the appropriate hospital, setting up facilities to understand how you got people to the right care for the right time at the right place. It's just an amazing ability to adopt with once war starts, the rules are out the door.
Yeah, no, I just thought that was a fascinating and helpful analog, and in a funny way, hopeful. The only one of the few things out of war that are hopeful. Robin, one of the questions that's come across, building on sort of some of the things that Daniel and Toby have talked about is, what are the chances of Priyash, what are the chances of overcoming the current inertia and moving from system-centered to patient-centered? Because we all have a real passion for that patient-centered piece. Maybe we'll take that question across, because I think each of you has something to add on that.
It's hard to talk about the chances a little bit. I'll stick to addiction because I don't know if I'm very well equipped, but to talk about the other pieces, or the other industries. But with addiction, what we're seeing is that patients are largely, so I think what's exciting about COVID is that, obviously we've been doing telemedicine for a long time, and we've always been able to collect a lot of patients that are early adopters of telemedicine. Otherwise, why would you go with Work at Health, right? So by nature of who we are, that's who we attract. Now we're seeing a much wider swath. So we've seen demand increase considerably across the board. Now, I think what's interesting about COVID is that patient demand is there, but now clinician demand is there. So it's not just about, patients want this for us, it's about our clinicians want this. And at the end of the day, it's quite simple. Like, the care we deliver is reliant on 2 parties, right? You have the clinician and the care team that is comprised of prescribing practitioners, be them nurse practitioners or collaborating physicians, whoever, and social workers. And then you have the patients themselves. And it's kind of the cat's out of the bag. Like, everybody wants to work from home. For us, we're talking about going back to brick and mortar for their first time induction, and clinicians don't want it. A lot of clinicians are saying, we want to work this way. This is easier. For them, it enables them to do their job better. There's a real breakdown of kind of the white coat syndrome, where I was just talking to a clinician this morning, one of our clinicians in Michigan, and they're really seeing blood pressure across the board decrease in that first induction appointment because the patient is at home. It's really scary to go in somewhere and to be shaking and have to talk about your drug addiction, et cetera, and things that you would never normally talk about. So I think that's serving us. And the fact, we didn't really start here, but COVID has kind of led to this dramatic, at least actually across the board with Medicaid, with originating site laws, it's led to this dramatic regulation change. And regulation is kind of hard. Once people are practicing a certain way, it's my hope, fingers crossed, that we won't be able to snap back. Maybe this is naive, but we've seen a lot of regulations come down the pike from a federal level, enabling us to practice telemedicine in rural areas, all the way to people with social determinants of health problems, et cetera. So there's been a big regulatory change and fee change. 2, there's been a big reimbursement fee change, which is even harder to put back in the bag when it's out, right? So now that health plans are paying for this, the thought is that they'll continue paying for this telemedicine intervention because of continuity of care issues now. What are you gonna do? Tell thousands of patients that suddenly they have to, put it themselves if it's no longer covered? So I'm hoping that helps, John, when you talk about, is this lasting or is it not lasting? And then 3, what I talked about at the beginning is the telemedicine adoption from both the clinician vantage point and the patient vantage point.
I still think it's going to be a bit of a battle, but Daniel, maybe you could speak to that both in the what it's going to take to be patient-centered, and whether you think the medical industrial kind of fee-for-service system will find a way to suck some of the life out of this innovation. Because there has been remarkable flexibility around licensure, reimbursement, and regulation, really pushed out from CMS faster than I've ever seen. Toby and I talked about that, but would love your thoughts on having, because you've been in the traditional system and the risk-taking system at Bright, as well as kind of you're to some degree engineering the future at Best Buy.
You know, I'm going to use a really quick non-healthcare example. This last weekend was Rosh Hashanah, the Jewish New Year, and I've lived in California, I've lived in Illinois, I live in Minnesota, and I actually went to multiple different services because I'd found this synagogue in California that I really liked, but I don't live there anymore, so I couldn't experience it. And this time, you know what? I could log in and experience it. And next week, there was a synagogue I used to go to in the Netherlands. I'm going to log in and experience that synagogue. And suddenly, the spirituality and the availability of high holiday services in the Jewish faith are democratized. And that same thing is going to be true and is true suddenly in healthcare. I can go to whatever physician I want. I need the technology to be in my home, and I need it to work for me. I need the data to go. So I need that technology, by the way, approved and over the counter, or at least approved in a way that I can use in my home. I need the data to go to the physician, and I need a machine learning or AI layer on top of that so that the insights are delivered. And then I need the physicians actually to remove the moats that they've created by keeping the medical record inside their own home. And once those moats are removed, which is already happening, right? There are drawbridges, et cetera, across medical records that are being built. That democratization of healthcare will give me the same experience that I wanted when I picked the service that I wanted to go to that made me feel most comfortable and most at home, as opposed to the one down the street that maybe wasn't perfect for me. I think it's going to happen. I think the technologies are out there. And I think that as soon as we create that right experience for people, people will choose who they want to see as a physician, as opposed to who's most convenient or who they're allowed to see.
Mm-hmm. Toby, I agree with that, Daniel. One of the questions is CMS has hinted about providing more flexibility around care to the home, but Karen wants to know, are doctors and hospitals ready to embrace that change and support it? And what would doctors need to have in order to support it faster and smarter? Because building on the data, the technology, I mean, a lot of us are building out that sort of bridge to the future, but we got to make sure that the doctors and the hospitals support the vehicles kind of moving forward. What's it going to take?
Well, there's two things that doctors respond to. One is finances and two is data. And you know, you can creep up on things slowly and small steps. One of the things that we did a few years ago is we realized that monitoring people's EKG on the floor was a ridiculous thing because by half the time no one was looking at the monitors. And so we decided that all of the EKGs in the entire organization would be monitored in one central location. I mean, one technician can look at 90 EKGs and if something happens, he can call the floor and it's get better monitoring than you would otherwise. That was the first small step. Then we said, okay, let's do ICUs. And so now all of our ICUs are monitored 24 hours a day by intensivists. And you can't get those sort of people to be up 24 hours a day in small hospitals. Now it's done two things. The data is proven that it reduces the mortality rate, it reduces the stay in the intensive care unit, and therefore it's reducing the cost. And now you've got the data to begin to show physicians that this works and you can roll it out. So you start with a small step, you're given the advantage of the data, and then you can move on from there. But the finances and the data are the keys to changing physician behavior.
Hey, Daniel, anything to add there?
Yeah, I agree with all of that. And you know, I do think there was a question that came across about the digital divide. And
Yep.
we are actually going to exacerbate inequalities in healthcare. We're gonna, we'll leave out rural populations that don't have broadband. We'll leave out Medicaid populations that maybe don't have technology available or don't have internet or change cell phone numbers frequently. And so we have to figure out collectively how we're actually going to address that. And a lot of payers are going to start subsidizing technology and probably connectivity for their members, because they want to ensure that those members actually have access to healthcare. But this doesn't stop at a healthcare system level. This doesn't stop at a retail level. This requires payers to be innovative and regulatory reform. And it requires physicians to be open to receiving information in new ways. And the traditional physician examination, it can still happen. It's going to look different. Data is going to come in differently, and helping patients use and adopt technology that might feel different and might be a little uncomfortable. We'll be able to help them over that divide as well, and I'm really excited about that part.
Yeah, I think some of the roles of innovators, I mean, certainly at CareCentrics, we've been able to drive more care to the home because we're providing more information back to the doctors. Because honestly, there's a lot of, there's sort of, even though the EMR may be in a walled garden, they're not a lot of doctors that want to follow up an insight don't have the bandwidth or the information, basic information about what happens post-discharge. And so I think that digital bridge, that the FHIR standards, the interoperability that government is pulling through, there's a lot of questions about government regulation. The reality is that CMS is forcing interoperability on a series of systems, as you know, Daniel, that don't really particularly want to make it easy or fast. But I think, the advantage of innovators like, Workit or CareCentrics, Robin, is that to some degree we can actually feed more information back to doctors, the covering doc, and that they wouldn't otherwise have. I don't know whether that's been your experience at Workit, but it's certainly gotten a lot of doctors supportive of stuff in our experience.
Yeah, definitely. I think you just have such a data game to play in some ways, right? Like, you have so much more data. You have data on their location. I mean, everything you could want, everything that Google has, you have the opportunity to have as well, with patient consent, of course. And I think that's powerful for doctors. Something at Workit Health with our product and design team from the beginning was always the mandate of our product and our design team. So I think of it as two things. You have the front end, so you have patient facing, and then you have physician facing, right? And with the product mandate that we employ is, how do we enable physicians and clinicians to do their job better, right? How do we get paperwork out of the way at the beginning? How do we synthesize that information in a note template that's not illegible from Epic? How do we serve them information that's relevant to this patient? Perhaps this patient, for instance, has, transportation issues or housing insecurity. Like, how do we serve them that? Or how do we arm them with the fact that this patient might have low bandwidth before entering the waiting room, or before entering the telemedicine appointment? For all sorts of ways we can do so much better. I would say, Daniel, to push on that point about accessibility and equality, what's interesting from our vantage point is that from the early days of Workit, some of our earliest partners were national health plans. So that forced us to think about how Workit would comport itself, for lack of a better way of saying it, in a myriad number of environments. So what we have is a lowest, like, MVP, kind of a lowest threshold of where Workit can be deployed. So we work on the lowest bandwidth. What did you say?
Minimum viable product for those who are not technical.
Yeah, minimum viable product. So where Workit can be deployed. So for instance, if somebody doesn't have internet, we really encourage them to go to Starbucks, right? Starbucks has great internet for the whole world to know. I mean, everybody knows this when we are in a pinch. So we implore them, we go to Starbucks, go to the bathroom in Starbucks and do your drug test, right? And so this is something that, like, I don't think typically physicians would think to say, but it's something Workit says because we have a really interdisciplinary team. And John, I think we haven't really touched on that, but I think it's important. Best Buy is a very good example of this, and to bring other industries, to bring like the superpower of retail into the clinical home. It's so exciting to think that like those two industries have merged to create create you, Daniel, to create you at the top. But you know, it's really it's a fun time to be in healthcare for that kind of merger.
And so what do you think Toby, you're sort of got a foot in both camps, and I know you're upset that the MVP wasn't referring to you, but as you think
that's a goat.
think about having a foot in traditional healthcare and a foot in some of the digital companies, and we're at CareCentrix are sort of a little bit of a mix of both. What do you think the new innovators have to bring to teach old healthcare, and what does traditional healthcare have to does it have to teach some of the digital first innovators?
Well, first of all, I think there's very little common capabilities between healthcare providers and the tech companies, and that is going to require a conversation that where both are listening hard to the other one's capabilities and needs. So that's the first thing, and some people have got to be brave enough to leave one area of knowledge and try and immerse themselves in another so that they can understand each other. And that to me is a potentially a very big opportunity. The second thing that I see is a huge opportunity is the ability to take the new technologies, the less invasive things, and bring them out of the hospital to the clinic, to the doctor's offices, and ultimately the home care, and shorten it. The third thing I think that is a dilemma for all of us, and I think we're kind of missing it as part of this discussion, is the fact that only about 20% of a person's health is determined by the healthcare delivery system. Yeah. The rest of it is the social determinants, where you live, your behavioral activities are really 80% of that. Now, unfortunately, the common denominator there is poverty. Just in Cleveland alone, within half a mile of each other, the life expectancy is 23 years difference in where you live. And so, ultimately, we're going to have to ask ourselves the question, all of us, how are we going to begin to address these issues if we're going to make a difference in chronic diseases and life expectancy and quality of health, which is enormous opportunity? Question really comes down to, are we going to do what European countries have done and invested more in social programs and less in healthcare and get better long-term results? Tough societal questions.
But the math appears to be pretty clear. And maybe speak to that, Daniel, because I think your point about it isn't just the digital divide, it's the divide, and perhaps how technology could help or not.
Yeah, one of the acquisitions Best Buy made in the last year or so is a company that actually has a push button that gets you linked directly to a social worker. You probably don't need a doctor, you probably don't need a nurse, but what you do need is someone to help you get food delivered or get a ride to a clinic if you need to go to a clinic, or just it's the social determinant. And if you can move your personal emergency response service button from a EMS dispatcher, from dispatching an ambulance to dispatching a Lyft driver with groceries, like what a transformation that's made. We know that you're more likely to get hospitalized for CHF exacerbation or COPD when your air conditioning goes out. Let's solve that. And I think that taking that holistic approach at the patient will really solve some of that. And by the way, it's not just the patient, right? It's who else is in their life. Do their family members know what's going on with them? So the number of patients I have discharged from an emergency department who I can't communicate with their family, and so there's a game of telephone with what happens next with them, what their follow-up plan is, what their medication adjustments are. How do we get caregivers involved throughout the length of that? How do we make sure that their home situation is correct? These are all significant problems that we're going to have to solve again as a society and not just as a healthcare system.
But I think
Just a second, to his point, it's interesting, United Way stepped in here and they now have a 411 number that you call in Cleveland, and it does exactly what he suggested.
Right.
But I do think you need to get engaged directly in kind of care traffic control, and I like the fact, Daniel, that you quickly moved from an ugly phrase, the social determinants of health, a phrase that only a healthcare economist would love, to whole person. Because if you're whole person oriented, you'll get those pieces. One of the questions that came in over the internet from Aaron, Daniel, maybe you could speak to this, is, it sort of implicitly talks about caregiver burnout. How does, one of the things we don't focus enough on, and we run into all the time when we're doing kind of post-acute care, is just how heavy the burden is for the caregiver, family or not, the person who knows you and is trying to help you navigate it. How can technology help lighten that burden and prevent burnout? Because it is now, and I think will be an increasingly large challenge for folks with multiple comorbidities, and particularly with an aging society.
Yeah, so I'm not going to pretend to have a great answer to that. And I don't think we have a good answer to that. What I do know is that that alert fatigue in the hospital setting, so all the alarms going off that we ignore, is not that different from alert fatigue for caregivers. And so as we collect data for someone caring for their mother, and provide all those data signals, and a random blood pressure or a random glucose,
yes,
to a child,
yeah,
who's watching the data feeds come in, first of all, we're probably not doing that, right? So like, we're not getting the right data to caregivers. It goes to the doctor's office or to a care management organization. But if we're going to feed data to a caregiver, let's do it correctly. Let's do it in a way that isn't interpretable, but is interpreted, so that someone knows what to do with information when maybe they're not a clinician themselves. And if we can start getting rid of alert fatigue for caregivers just as one part, I think that'll actually help a lot. And again, so Toby, go.
So let me jump in here. I think one of the things that has really driven caregivers to incredible burnout is the overload in data. And you stop and think about the number of articles. There are 5,000 journals putting out 300,000 articles a year. Who on earth can possibly keep up with that? And this overload of data is coming in, but how are we going to handle that? Well, the answer has to be technology. We have got to figure out how the technology harvests all the data that is coming at the caregiver and gives you a thoughtful, scientifically based, experience-based approach to how you handle the situation with all this enormous data. Can't possibly do it all yourself. How do you possibly pick all the right chemotherapy agents when you have to have the human genome of the patient, the genome of the tumor, and all of these will be thousands and thousands and thousands, if not millions, of data points in order to try and make these decisions. We have to have technology help.
And I want to just build, Toby, on a point you made earlier, which is I do think that if you give people the voluntarily allow them to choose to share their data in their best interest. We found that at one point, one company we covered 30 million employees, and 70% of the employees, when asked, said they would participate in sharing their genomic data for medical and research purposes. The challenge is when you're not clear about sharing that data, because if we could share that data, I think you could build those simplification alerts. How do you get folks to engage and voluntarily join your program, Robin? Because that's a big step for someone to kind of commit. How does that personal engagement work? Because if we can get that right, I think we could get more folks engaged digitally to enhance, because I think it's it's going to be healthcare augmentation versus replacement if we're going to get the digital and medical industrial complex relationship right. How do you folks deal with it from a patient or an engagement perspective?
Yeah, I think in many, many different ways. I think tactically, different. I think we have different tactics so that the strategy is the same. we always start by talking up, not down. So that's kind of one design aphorism. That's one design tenet that we use across the board, right? Like we don't treat people, because somebody said it, I think it was Toby that talked about treating people like infants and fantasizing a bit. And we try from the very beginning to get patients to engage with their own data. I think secondarily is understanding that in 2020, they want their medical record, right? Like if you're on a digital device and you're talking to your doctor, of course you think that there's a digital transcript. And patients I was just reading about a few cases actually. CMS is involved in a few cases where patients have requested their medical records and didn't receive it from these health groups. And this happens across the board widely. So I think understanding that context is driving this. And if you're approaching somebody in a digital environment, they're going to want the digital record. And when you give the patient data, of course, like how do you arm them with what Toby's talking about, with the relevant points first? And then the buy-in, like every step of the way, always in user experience world and product design, you always want to have this co-occurring buy-in. So one of my favorite digital health companies is called Modern Fertility. And they have this beautiful disclaimer. Instead of just saying, click, terms and services, privacy agreement, like all apps do, they talk about what they're going to do with your woman's health data, right? They say, we're not going to sell it. We're going to use it for research. We're going to do this. We're going to do that. And then they have a section of their site where they just keep asking you questions that is related to data. 23andMe does this really well. And I feel, even though I'm given of data, right? Like I'm supposed to never do this on the internet, I feel like an active participant. And so it's just one small example of sharing the load and sharing that cognitive load, especially of care with the patient. I think Best Buy is another good example. If a patient, if they're helping to arm themselves with the ability to set up their home as a medical home, whatever medical problem, Alzheimer's is a great example, you're going to have more buy-in. You're going to have more they're going to feel more agency, and they're going to feel more of a commitment to you. So I think that's a different way of practicing healthcare, a much more consumer, patient-centered way, but I think it's necessary if this is going to work.
Yeah, totally agree. Daniel, there's a question that came in over the internet that people want to know, how do we get all these digital resources? They're looking for a digital health mall. Is Best Buy going to provide that?
So, I mean, that's one of the goals, right? Is if we asked ourselves, where would you go today? If you start with the premise that technology will drive healthcare, I don't think there's anywhere to go today where you can get the technology resources that you need in your home to help bring to life this idea that the home is a site of care, and that should be the natural position of a technology company like Best Buy. And we have some of those products that right now link you to a clinician, like a TytoCare, for example, or a Kinza, which not only parents use, but also is predictive of spikes in COVID and death rates around the country. Like that data is clear. These technologies exist, and yeah, we have them. We need to have more of them. We're actually gonna sort of blow out this curation of health oriented technology, but that doesn't exist today, and we need the physician community to actually push people to buy sort of that suite of solutions. Also, we need payers to say that suite of solutions will change outcomes and will be good for our business. Go there and get it, wherever that there may be. And that probably, we haven't crossed that hurdle of the mountain yet.
So Toby, are you hopeful or are you not about all these changes we'd like to see in technology first, patient-centric, tech-enabled healthcare?
I'm very excited about it. Quite frankly, I think that we are entering into a much more malleable, flexible healthcare delivery system than we've seen before. And I think the pandemic has opened our eyes to new possibilities and new ways of doing things, which I think that we'll have a reset as a result of this. And I think that's a very healthy thing, although it's been very, very painful to go through. So I'm very excited about it.
Well, we've been in a war, and wars change everything, and I think that there's a lot to be optimistic in elements in everything all of you folks were hearing, and I'm humbled and honored to do this with you, and thanks for making the time. I believe we are at time, and I don't know whether the health folks are going to take it from here.
Thank you, John, and to all of our panelists. If you'd like to continue the conversation, please join us on Twitter. And now, take a break from your day